Sharing evidence on making savings is going to be key. What we're asking for, and I'm asking you right now, and it'll be coming out later, is can we have some evidence of your good practice? What do you do that actually saves the NHS bagloads of money right now? Because that's the kind of thing that everyone's desperate for. If you're really pressed, PCT organiser, planner, commissioner, whatever, you need to know what that bit of good practice looks like so you can build on it. So please could you let us know? You can let me know, you can let Steve know, you can let Rebecca Hardwick know, you can let the NHS know, but make it very obvious. Look at yourselves, think, if I wasn't doing this, this patient would have this happen to them, that would cost so much to the NHS. And look, I'm only spending 10 pence, they'd have to spend £1,000. That's the kind of information and evidence we need. It's a very exciting podium up here. Keeps moving. We need to work on those infrastructure bodies because this is the time that they need to be active. They need to be communicating between their constituent bodies and also the statutory bodies in their patch. So there are recommendations about that. The second area of work was in public engagement. We are all very anxious, I think, about how this is going. Link maybe had some problems, but the future looks not clear that it's going to be able to put at the centre of developments the patient experience. We need to be aware as a voluntary and community sector that we have fantastic social capital, and our capital is based on two things: our knowledge and insights of the people who we are, who we work with, and also the trust which the general public puts in us. If we make a recommendation or endorse a recommendation about, say, a service reconfiguration, we are likely to be trusted in a way that statutory services aren't. For instance, in my business, which is end-of-life care, if they reconfigure cancer services because actually the medical evidence says that's a good thing, the public normally says the NHS is just trying to save money and they're hating us and it's all awful. If they come to the hospices and ask for opinion, and this has happened to me, we had it in Dorset where I work, and I was able to say medically and for the care of the patients and the downstream work we've done, we think this reconfiguration should take place. Because we were trusted to be on the side of the patient, then politically that became an acceptable thing to do. And actually as a result of that, lives have been saved. That feels pretty good. We have that social capital and we can use it very well if we want to, but it's quite a mature thing to do. Keeping that social capital and building on it is something there was also a big opportunity for now. As you will know, the Mid-Staffordshire report, the next open inquiry, public inquiry, started on Monday. The first thing Robert Francis said, having done a closed inquiry last year, was he wanted to pay tribute to the voluntary sector groups that brought together the patients' voices and insisted and insisted and insisted something was done, as opposed to the statutory groups who failed to hear those voices. The NHS is very, very anxious about the quality side of all the agendas. They are very, very frightened that things like Mid-Staffordshire could go on and not be noticed by any of the statutory structure. And they are beginning to understand that the people who know are people in this room, because they have that ear and they have that confidence and they will keep speaking. This has been a social capital we all need to be building on to make sure that when the new Health Watch or whatever it is evolved for public engagement, both in the NHS and in local authorities, that it's done in a way that is real, that really will listen and be accountable, not to the vociferous people that sometimes always get their voices heard, but to everybody. And again, we have a fantastic role in making sure there's comprehensiveness in that. The GPs don't have that ear. At the moment, there's a fair amount of evidence the GPs don't think it's quite interesting. And when they become commissioners, they need to understand very, very quickly it's extremely interesting. And it is, again, it's a pivot point where we can use our social capital in order to get GP consortia to engage with us as people they depend on for their commissioning and also for the delivery. The middle point is about our role in feeding back a very even-handed view of the changes that will come out of CRIP. CRIP will lead to some services either altering or closing or being decommissioned. Now, it's very easy to get into a knee-jerk of decommission is bad, but actually if a ward is being decommissioned because the services are being provided by services nearer home, or it's being decommissioned in order to let that happen, and actually you've been campaigning all your life for these services to be provided closer to home, then don't go and attack the NHS for closing the ward, because they're doing what you wanted them to do. You need to see the bigger picture always. If you want to be trusted as part of this change process, you need to be trusted. And you won't be trusted if you always go into knee-jerk, own organisation reaction. And it's a conflict for some people, it's a conflict for some organisations who see themselves as battling always for one cause without seeing the bigger picture. It's part of their governance that they do that. But if you want to be part of the game, you need to see what the game is and be on the same field. And at a national level, we also need to be working with regulators to make sure that the CQC understand what quality of public engagement and user feedback is. There's no evidence so far that CQC know which way is up when it comes to that, let alone what is down. So that is a real role for Akivo, which is the national body that's been working on this, to work with CQC. Again, galloping on for change, because we have little time. Just the process of managing change, because we are all in a hiatus. We thought it would be a good idea if we all shared our lack of knowledge of what was going on. And we actually have a schema of getting 6 monthly national and then regional, then local updates on the changes. Now this requires us all to understand that these may be contradictory, so what is published in June and what is published in January may be completely different. So that is how life is at the moment, and it's no good going to your local PCT and saying, but you said that, because they will tell you in good faith who is doing what, where, which bit of the community service is moving to where and who's taken charge of it, as much as they know. I know locally, I need to know who am I speaking to this week, because it keeps changing. So there is a commitment to sharing that information. But there is also a real worry in the NHS about sharing information before a decision is made, before it's black and white. So there are ways that probably needs to be done through the infrastructure bodies, so it's done in a very considered way with all the caveats in, and not in a headline way. Stuff that can't go straight to the newsletter of the public. If we want to have that inside track, then that's the way we're probably going to have to do it. So again, the infrastructure organisations are absolutely key. And we need to share that information. And it's a two-way process, because absolutely as we are reacting to changing circumstances, the NHS needs to know where we are in all of that. And there's a national recommendation for Akivo to join the NHS family through the Confederation. So just to conclude, we think there's much more opportunity during a time of crisis when it's all easy. This could be the big time for making a cultural shift. I mean, everything else is shifting, about getting the VCS seen to be not disparate and difficult and not understanding, but in fact cohesive, trusted, expert, and actually that key to quality services that people will need. I think everyone realises that going to siege mentality and saying, as I regret to say, in another region, one PCT did to all its voluntary community groups who had grants, could you pay back this year's grant, please, because we've run out of money. I'd say no PCT in the southwest would be allowed to run out of money, not twice. But that kind of retrenchment is not helpful, and everyone recognises that. But that we should be part of a healthy mix. But both parties need to reappraise their stance. And what was fantastic, we did have commitment from the NHS all the way through this process, and we'll be working furthermore through the SHA and the PCTs to keep that going. Challenges, the next steps, is we want these examples of good practice, please, and I will be putting up my email, but I think the South West Forum probably could receive them, and we'll bring them together. We're asking people to be really proactive and not ask for it to be done to them, or expect the NHS, which has all these other pressures to deal with, to be making the money. It's you guys got to make the money, and if your local infrastructure organisation is pretty rubbish, then it's only pretty rubbish because you've allowed it to be. There isn't another room full of people like you who's going to make it get right. Okay, it's you guys. So make it right, okay? Just do it. The public health white paper and the whole thing about review social care, it was not part of our remit, but of course huge challenge there. We are aiming to review how far we've got with dissemination and whether it's made any difference at all in spring 2011. I'd like to thank the task force. These are the faithful ones who turned up to all the meetings and responded, and that's my email on the bottom. And good luck, we're all needed. But we're doing this for the patients and users who happen to be ourselves. Cheers.
Thank you, Alison. I think we're going to go straight on, if we may. Thank you very much for that both reflection on the kind of call to arms, I guess, and the call to action and the recommendations coming out from the task group, which you chaired, Alison, but also from your perspective, from sharing actually what's driving the health service, what the kind of feelings, what the tensions are, what the challenges are. You're in a very good, privileged position, both as a chief executive of a social purpose organisation, but in your role as a non-exec, and we really appreciate that. Thank you very much.